This week in our course, we are up to Chapter 12 on antipsychotic drugs. We are focusing on schizophrenia. The antipsychotics are the primary treatment for schizophrenia, as well as other psychotic disorders. We're focusing on schizophrenia, but the treatment applies across psychotic disorders in general. So the nature of schizophrenia, it's characterized by losing touch with reality. At times it can be brief and temporary, especially if caused by drugs. Hallucinogens cause hallucinations. Some drugs can cause paranoia or other symptoms like that. So these drug-induced psychotic episodes tend to be brief. With schizophrenia, the word means a break between thought and behavior. You can see the diagnostic criteria in box 12-1. So generally, there are positive symptoms as well as negative symptoms. Positive symptoms is where you gain something. It's not a good thing, but you gain symptoms that aren't normally there. And then negative symptoms is where you lose something. Something that is normally there is lost. So the positive symptoms are listed below: hallucinations, delusions, disorganized thoughts, and disorganized behavior. You can see, so hallucinations can include any of the five senses: visual hallucinations, auditory hallucinations, where you hear something, maybe you hear voices; tactile hallucinations. We were talking about formication, the sensation that bugs are crawling on your skin, something like that. And then olfactory and gustatory hallucinations are less common, but that's where you smell or taste something that isn't there. And so this is a sensory experience. And then in contrast, delusions are their beliefs or thoughts that aren't true. Someone might believe that there are people out to get them, or that they're being followed by the CIA. These are thoughts or beliefs that are not based in reality. Disorganized thoughts are not logical or connected. And then disorganized behavior is where a person doesn't act in a way that makes sense with their context. And then negative symptoms is, again, something lacking that should be there. That's something that would normally be there. So the 4 A's are listed here: affective flattening, alogia, anhedonia, and avolition. So an affect is a person's emotional expression. A flat affect is appearing to have no emotions. So you have a deadpan look rather than laughing or expressing pleasure or anger or whatever the case may be. Their face doesn't express emotion. Alogia is a lack of words or speaking. They're withdrawn and they don't talk. Anhedonia we've already discussed, but it's a loss of interest or pleasure in activities that a person normally enjoyed. And avolition is a lack of motivation. It's where somebody just wants to sit there all day or for a long time without really doing anything. These symptoms most often appear gradually over the course of years even. And there's certainly some genetic involvement, but there's no one schizophrenia gene, and it's likely an interplay of several genes as well as environmental factors can contribute to this. There are several different theories of schizophrenia and some data to support these different theories. So first is the brain structural and functional abnormalities. The people with schizophrenia have less brain tissue. The volume of their brain is lower in up to 50 different brain regions, and that includes several different areas of the brain. Those are listed in the book. And then additionally, this gets more severe. It gets worse over time, and it gets worse with each psychotic episode. The ventricles, the space where the cerebrospinal fluid resides, get larger over time. And it's important to catch schizophrenia early so that the brain, because otherwise the brain continues to deteriorate. Patients tend to respond a lot better earlier in their disease to different medications. Next is the dopamine hypothesis of schizophrenia. The idea here is that people with schizophrenia produce too much dopamine at synapses, and people with dopamine deficiency, in contrast, people with dopamine deficiencies exhibit Parkinson's symptoms. You can treat psychotic disorders with medications that block dopamine transmission, and too much of that, if dopamine is blocked too much, it can cause people to exhibit extrapyramidal signs and symptoms, Parkinson's-like symptoms. Um, this is called, or one example of this is called tardive dyskinesia. This is mentioned in the video on the learning module if you want to take a look at that. This happens more with the older medications than the newer generation of antipsychotics. The revised dopamine theory is that schizophrenia is caused by excessive activity at specifically D2 receptors, and newer drugs can still target dopamine, but they do it in a more nuanced way. We'll talk about that a little bit later. The glutamate hypothesis of schizophrenia came about because stimulants, cocaine and amphetamines, can produce symptoms like the positive symptoms of schizophrenia, and PCP and ketamine, two dissociative drugs, produce similar symptoms as well, both the positive and the negative symptoms of schizophrenia. And the binding sites for PCP and ketamine are on the glutamate NMDA receptor we've discussed before. And the ability of these drugs to produce schizophrenia-like symptoms depends on their interaction with the NMDA receptor. So it depends on their antagonizing glutamate function. And then in addition, many of the genes that contribute to schizophrenia are also involved with the connectivity of glutamate neurons. You'll recall that these neurons are found throughout the brain, so problems with their connectivity, the connectivity between these neurons can affect all kinds of different parts of the brain. And then, of course, glutamate and dopamine interact, so these theories are not mutually exclusive. And you can see in figure 12-1 a little schematic of some of the glutamate and dopamine interactions in your brain. And there's a little description there of how glutamate dysfunction might cause dopamine dysfunction as well, to then cause some of the symptoms of schizophrenia. The first generation of antipsychotics are also called typical antipsychotics, and then the second generation are also called atypical antipsychotics. You can see a list of a bunch of different typical and atypical antipsychotic medications in table 12-1. Typical antipsychotics were the first generation developed. They were developed by surgeons in the 1950s, noticing that anesthetics had a sedating effect on patients. And they started recommending these medications to treat agitated mental patients. These are phenothiazines and butyrophenones. So there's 5 subtypes of dopamine receptors: D1, D2, D3, D4, and D5. D2, 3, and 4 are the receptors, the dopamine receptors that are of primary interest for psychotic symptoms. And the typical antipsychotics primarily block the D2 receptors. These are most effective in treating the positive symptoms of psychosis rather than the negative symptoms. But when the D2 receptors are blocked in high enough numbers, at something like 60 to 80% occupation, these drugs can cause Parkinsonian symptoms, the EPS symptoms that we were talking about before. These are also called neuroleptic symptoms, and another name for these drugs is the neuroleptics. So then atypical antipsychotics, the second generation, cause much fewer of those side effects, the Parkinsonian side effects. Clozapine was the first one developed. It's possibly among the most effective, but it also carries problems because for some people develop problems with their white blood cells, so it's not a first-line choice for most people because of that. But in any case, these atypical antipsychotics primarily block the D3 and D4 dopamine receptors. They bind much more weakly to D2 receptors. So in figure 12-2, you can see a visualization of the dissociation constants for typical and atypical antipsychotics. You can imagine, so you see the line on the left side, panel A, you see the line that shows the binding constant, the dissociation constant for dopamine. The way to think about this is that it's like a pKa, where the pKa of a certain molecule, that's the pH at which half of it will be ionized and half of it will be unionized. This dissociation constant is the concentration at which half will be bound and half will be unbound, half will be free. So higher concentrations, higher numbers mean that the binding is weaker, and you have to dump in a lot higher concentration before half of it is bound, if that makes sense. Lower numbers means a tighter binding. And in this figure, the typical antipsychotics are represented by unshaded rings. The atypical antipsychotics are the dark rings. So you see that above the line representing dopamine, you have almost all atypical antipsychotics, and below that line you have almost all typical antipsychotics. There's a few exceptions to that rule, but that's how you can interpret that figure. Okay, so let's see. There's a much weaker binding to D2 receptors as compared to the typical antipsychotics. And again, the increased occupation of that D2 receptor, something like 60 to 80% occupation of the D2 receptor, can lead to those EPS symptoms. So the atypical antipsychotics avoid this side effect, which we've already said. There's also a difference in how these medications interact with serotonin receptors, specifically the 5-HT2A subtype. The first generation blocks these to some extent, but the second generation have a much higher affinity. And again, you can see this in figure 12-2, this time on the right side. And now it's a comparison of the ratio, dissociation constant at the D2 receptor divided by the dissociation constant at the serotonin 2A receptor. So high numbers mean that they have a lot higher dissociation constant for the D2 receptor as compared to the serotonin 2A receptor. Low numbers mean the opposite. They have a higher affinity for serotonin, or for the serotonin as compared to the D2 receptor. So that's how you can interpret the right side of that figure. So that might be one reason why the second generation drugs work better on negative symptoms than the first generation, because of the role of that serotonin receptor. And then Abilify or aripiprazole, some people consider this to be a third generation drug, but many still consider it to be a second generation drug. But it does work differently than other atypical antipsychotics. It's a partial agonist to D3 and D4 receptors. So it binds the receptor and has a partial effect, or it has a modulated effect compared with dopamine binding to the receptor. So in areas of the brain with too little dopamine activity, it acts as an agonist. It does bind the receptor and it partially activates it. But then in areas with too much dopamine activity, it can bind and lower the activation of those receptors. So it stabilizes dopamine activity overall, and it has a good effect on positive, negative, and cognitive symptoms of schizophrenia for many people. These drugs are most often taken orally, but they can be given with injections as well. And given as depot injections, a big plus there is that it might help with compliance. You don't have to trust a patient to take their medication on a daily basis. You can give them an injection and they're good for weeks or a month or whatever the case may be. We talked about depot injections back in chapter 1, but then most of these drugs are readily absorbed by the digestive system. They tend to be pretty highly lipid soluble, so they're absorbed into body fat and then released slowly from there. They easily cross the blood-brain barrier. That might be obvious already because they're active in the brain. And they also cross the placental barrier easily. There's a lot of variation from person to person in the metabolism of these drugs, so it's a process to find the optimal dose of these drugs. It's trial and error to find the right dose for everybody. For typical antipsychotics, the half-life is on the order of a day or two, 11 to 58 hours. And the book mentions that metabolites can be found in the urine months after treatment with typical drugs. And then that's, of course, especially true with the injections that are meant to last for a long time, the depot injections that we were talking about before. Cytochrome P450 is these enzymes are key in how the antipsychotics are metabolized, and there's a lot of different drugs that interact with cytochrome P450 enzymes. So depending on what other drugs people are on and even your diet can affect these enzymes. So that's another added layer to why the dose is often hard to pin down for people. The effects of antipsychotics on the body vary from person to person and from drug to drug. So with typical antipsychotics, and again, these are not used as much anymore with the atypicals, the second generations that have been developed. But with the typical antipsychotics, we've already talked about the Parkinsonian symptoms. Another thing we've already talked about is tardive dyskinesia, where people have these involuntary facial movements, tics or grimacing, some kind of unpleasant facial movement like that, that are generally irreversible. Akathisia is a general restlessness. It's similar to anxiety, but it's not as much as with an anxiety disorder per se. It's just kind of feeling keyed up or on edge and restless. Then people have trouble regulating their body temperature. People often gain weight. And there's several other side effects listed in the book. Cardiac problems and blood pressure problems. And these drugs are notorious for having very low compliance. Very, very few patients take them as prescribed because they just have so many negative side effects, and it's difficult to get people to stay on them as they're supposed to. Clozapine in particular, we've talked about the blood disorder that it causes. It's called agranulocytosis. So 1 to 2% of people develop this blood disorder, which is a problem with the white blood cells. And the drug's very effective, but it's just not used as often because of that very serious side effect. The atypical drugs also have side effects. There's problems with glucose metabolism and fat regulation. So similarly with the typical antipsychotics, these can cause weight gain. These can even cause diabetes onset, problems with cardiac function, and again, the book lists a bunch more. These drugs can also have effects on sleep. They're sedating, so most of them lead to increased sleep. Of course, some of them more so than others. And Seroquel is one in particular that's often prescribed off-label as a sleep aid. These drugs are not lethal. They're very safe, and they have therapeutic indices of 100 or even up to 1,000. So the dosages that would be required to kill somebody would be on the order of 1,000 pills. So yeah, they're not lethal. It's almost impossible to overdose on these drugs. The subjective effects of these drugs, they cause people to feel tired. We already talked about how they're sedating. People report feeling confused and not being able to concentrate. People are clumsy. They are sleeping more. They feel dejected. They also feel anxious and irritable. Simple tasks just take more effort than they should. Haloperidol is a typical antipsychotic that is used these days, in contrast to what I said on the last slide. And it's used especially with inpatient treatment, just to kind of de-escalate people who come in and might pose a threat or a danger to other people. So haloperidol or Haldol, people have reported feeling aroused and sedated at the same time, which seems like they're opposites, and it's not possible to feel both of those at the same time. But they basically feel restless and anxious, like they need to do something, but also sedated, like they're unable to do that thing. Overall, these drugs are reported the subjective effects are not pleasant, which is a big part of why these drugs have such poor compliance. And then effects on performance. The primary cause of impairment is due to the sedative effects. So with driving or operating machinery or anything like that, these drugs are going to impair performance on tasks due to their sedative effects. In the case of chlorpromazine, it causes dissociation. So the book describes an experiment where rats were unable to remember what they had learned when they were tested, what they had learned under the influence of the drug, when they were then later tested under the influence of saline. But they could recall the task. They did recall what they had learned when they were returned to the drug state. So that has implications for patients in psychotherapy who are taking antipsychotics. It's evidence that people might dissociate what they learn in psychotherapy or in any setting under the influence of antipsychotics and when they're off of those drugs. Also, people are not able to discriminate these drugs unless they're given at very high doses and with a lot of training. So especially compared to other drugs, they're quite indiscriminable. The therapeutic effects of these drugs show very little tolerance. So once a patient is stable and on a good dose of one of these drugs, they can often be maintained on that dose for a long term without needing to increase the dose. But some of the effects of the drugs do show tolerance, in particular the sedation and the Parkinsonian symptoms, EPS, do show tolerance, so that's a good thing. The side effects lessen, but the efficacy of the drugs do not over time. And then physical dependence withdrawal symptoms are mild and relatively rare. This is possible. It's possible this is true because of the long half-lives of these drugs, so they're eliminated really slowly. We've talked about before, with a shorter half-life, you're more likely to have withdrawal symptoms and more severe symptoms because your body had this drug and now all of a sudden it's eliminated from the levels drop very quickly. Versus if the elimination is very slow, the half-life is very long, the levels decrease just very gradually, so your body has time to get used to the decreased levels. So they're rare, but there have been reports of muscular discomfort, increase in psychotic symptoms, the movement disorders that we've talked about, and then difficulty sleeping. Because these drugs don't produce a euphoria, they're not readily self-administered by laboratory animals, and in fact they're aversive to these animals. The animals have learned to avoid these drugs. And then antipsychotics are not typically abused by humans. There's some evidence that some of these drugs they have some abuse potential, they have a street value. Seroquel in particular can enhance the effect of opioids, and it has street names. So, but in general, these drugs are not abused by humans, and in fact, low compliance is a big problem with self-administration in humans because because these diseases are highly stigmatized. When people are feeling okay, they often discontinue their medication, and that triggers a relapse of the symptoms. And it's not just because of because the diseases are stigmatized, but also because of the side effects that a lot of people are experiencing, just what we've talked about over the last few slides. And so then that can start a downward spiral, because the more psychotic episodes a person has, the worse off they are. Their baseline that they're trying to get back to is lowered with more psychotic episodes, and their prognosis becomes worse and worse as well. Reproduction is one area with a lot of harmful effects, side effects for these drugs. So males tend to have a lowered sexual interest and an increase in the hormone prolactin. This is a hormone that regulates breastfeeding in women, um, but obviously not in men. Females then have abnormal menstrual cycles and can also experience infertility, and then both sexes often see an enlargement of the breast, and fluid can come from the nipples, again because of the prolactin. Metabolic syndrome can also be caused by these drugs, and this is a set of symptoms that we're still learning a lot about. But basically, people have an increased cholesterol and problems regulating their blood sugar. So this can lead to diabetes, and you see a lot of people who are overweight and with heart problems, and all of those things kind of add together um, to be what we're calling metabolic syndrome here. Antipsychotics can also be used as antiemetics. They prevent nausea and vomiting, so they can be used as treatment for motion sickness or something along those lines. As they were originally developed, they can still be used as pre-surgical and pre-anesthetic medications. And then they can also treat movement disorders, so especially those that result from excess dopamine. They can treat Huntington's and Tourette's. Paradoxically, they can be used to treat tardive dyskinesia. And then the book also mentions hiccups, stuttering, and delirium tremens that come from alcohol.